Welcome to the Codecast podcast. Real-world insights for your daily medical coding and billing processes. And now, here's your host, Terry Fletcher.
Hello, everyone, and welcome to the Codecast podcast today. My name is Terry Fletcher. I hope everyone is having a great day and a great month of March. This is our 231st episode of the Codecast podcast. And my topic today is asking the question, have you ever had a patient medical record chart review? And I'm asking that because we have a lot of requests right now for medical records reviews, chart reviews, etc. And a lot of the practices have never had one. And the errors we're finding, the actual undercoding we're finding, and just with all of the audits looming with CMS, HHS, OIG, you may want to consider it if you've never had anything like that. And let me just kind of give you some background on that and why. So you really should periodically conduct even in-house chart audits. And what you're looking for, whether it be your office manager, your billing staff, your coding staff, which it should be a collaborative effort, and see if you can pull in either a mid-level provider or a physician offer the clinical aspect. But you should conduct a chart audit to assess whether your physicians and actually your mid-levels as well, don't forget about them, if they're coding and documenting accurately and can they support any of the claims that are leaving. But how do you know that they know what they're doing? So spending several thousands of dollars to bring in an outside consultant, yes, that can be expensive, but it's more expensive if you actually end up with a formal audit and you have to refund money, you have fines and penalties, and then it targets you for future potential auditing. But you need to know if your practice is doing a good job coding and reporting. And a far less expensive way to try to figure this out is, first of all, let's see if you are actually coding correctly from something you're doing within your practice, okay? So let's first look at your in-house and just see if you have the staff that can maybe look at something. So have your coding and billing staff get together, pull 10 charts per physician. So I've had a couple of requests recently, and just so you know, I won't accept this request. Somebody said, well, I just want you to look at 1 or 2 charts or 3 or 4 charts. I won't do it. The reason I don't do that is because you can't really get a trend. You can't get a feel for it. And when Medicare does a focused audit, they look at 20 to 30 charts per patient for a specific patient, for a specific code or a specific set of codes, like outpatient established visit, level 3 and 4, or outpatient new patient visits, only level 5, or hospital visits, only the hospital admit, level 2 and 3. So they're looking for a trend. They're not looking for, a physician just to pick the 2 best documented services and say, oh, this is how I document and this is how I code. So you want to basically have your staff pull at least 10 charts per provider and then copy those charts and hold them to the side. But then I want you to basically look at these charts, review these charts, and see if you can spot trends yourself. And what are you looking for? You're looking to see, first of all, based on let's just talk about E&M, based on the current 2021 documentation guidelines, did the physicians or the providers, if you use mid-levels, did they do everything needed to be able to support the service when it comes to addressed problems, data points, and also medical decision-making? And then next thing you want to do is you want to make sure that, okay, does your billing staff and your coding staff understand coding and have a discussion amongst yourself whether you do, and then find out when your physicians last took a training class. I was giving a class the other night for about 35, 40 physicians from a Chicago group, and I actually polled the audience and said, how many of you have taken a class? And there was, I think, 4 nurse practitioners, 2 billers, 2 coders, and then the rest were all physicians. And I had one physician say, I took a class when I was in my residency. I'm like, oh my goodness. So there is a lack of education when it comes to coding and billing and documentation and provider rules, payer rules, things like that from Medicare and the different plans, and even the organizations that are the peers. So the lobbying effort, if you're cardiology, ACC, if you're orthopedic, AAOS, if you're gastro, AGA, and and if you're OB-GYN, ACOG, it just it goes on. If you're family practice, AAFP, and I'm actually their external educator and auditor under the Family Practice Association. But the thing that you want to do is you really want to not just do it internally, but then confirm with an external consultant. And again, this isn't to build up my business. I'm busy. I'm here for you, but I'm busy. So I'm trying to get you to really recognize that this is a serious business. Most physicians, just from my research, they actually undercode more than overcode, or codes are not captured. And you could be missing thousands of dollars from not actually having an external chart audit to confirm what you are finding internally. So how do we charge that? So if you're a member of my Coding Corner, which is for coding questions, it's $35 a record. If you're a non-member, it's between $40 and $50 depending on what you want per record. So, and again, I have a minimum of 30 charts, but it's 10 per provider, or if you only have one provider, then that would be 30 for that provider. But you want to really take a look at this. Now, if you're a smaller practice, maybe you don't have the staff to do something internally to look at this or at the time. And so it may be something you want to consider to send, to maybe find an external audit. And a lot of times, the smaller the practice, the more hats people are wearing, and sometimes it's less practical to have an internal audit. Now, bigger practices, I've noticed, they usually have auditing staff, but that doesn't mean just because you have auditing staff that they've been educated or updated lately on the new rules, or that sometimes you kind of get into a rut sometimes because you're used to seeing what your provider is documenting. And so sometimes you'll see things that aren't there, or you will make assumptions for your provider. Well, this is what I know what she meant, or this is what I know what my doctor meant, and you can't do that. And so you have to make sure that you're not running into a compliance issue by putting things in a record just by thinking it's there when it's actually not there. I've actually had that happen on several practices. I'm like, where are you getting this information? I'm not finding it in here. And I thought I was crazy. And they're like, well, what the doctor actually meant was, I'm like, no. There's no assumptive coding. There's no assumptive anything when it comes to documentation and information. And one thing you should know, the Department of Justice just put something out, and they said that healthcare fraud and abuse is the number 2 priority for them, second only to terrorism and violent crime. And HHS, which is the branch of CMS, they estimate that $17 is returned for every $1 invested in fraud and abuse and basically bad documentation, coding, and reporting. And so it's really important. I mean, talk about a great profit margin. So you want to make sure that you can be proactive and find that money if it's necessary, but also really, be proactive and really start to think about having an audit. If you can start it internally and then confirm with an outside auditor who has experience in your specialty, then that's going to be really important, because then they will know what to look for. Perfect example. So how I actually start an audit is I want to see some ledgers. I want to see how things are billed out. And right away I can see some issues. I had a practice that they're billing and reporting more for a heart cath than they were for the intervention. So their dollar figures were off. And I noticed their trends on their reimbursements were reflecting this incorrect reporting of how much they were charging for the service. And so the stent, for example, or interventions are reimbursed around $600-700. Heart caths are reimbursed between $200 and $300, but they were charging more for the heart cath and incorrectly modifying those services. And the payers were like, sweet, we're making some money here. I saw another dermatology practice where they were forgetting to also code for a layered closure if it was beyond simple. I had an orthopedic practice. Oh my gosh, this is the best one ever, where their office manager had told the practice, had been there probably 25 years, and had said that she was told, and I always love that excuse, well, it's always been that way. She was told that you don't bill the medicine when you do knee injections, joint injections, because it's included in the injection code. Oh my goodness. Oh man, my head exploded. You're paying for that medicine, and there's specific, as most of you know, specific HCPCS codes, or codes that actually reflect reporting of that service. Now, we don't get the 20% markup we usually get, but at least we get what we paid for it. I had another practice, and this was family medicine, where they were not charging for a split visit when the patient came in for a preventative service, and then they had to do a separate workup because of a reported complaint that needed a workup that day. Not an incidental finding, not a refill of medications, but something that was specific. So patient comes in, they're there for their maybe pap and pelvic, their yearly exam. And then they say, can I show you my right toe? It feels like it's really hot and red and a little discolored. And the doctor's like, oh my gosh, now we got to go send you in for an ultrasound. Let me work you up. How long have you had this? And there's a possibility of, lower extremity atherosclerosis or problems. That's a split visit. And so those are things that can be missed. I had, other practices where I'm like, okay, can I just see a list of all of your welcome to Medicare visits and your annual well visits? And they're like, oh, we don't do that. It's not enough money. I'm like, what? So I swear I hurt my neck from spinning my head around a lot. But I'm just like, okay, well, you're seeing over 200,000 patients a year, and you're not billing any of these? Do you know how much money you've just lost? And we estimated over a period of 3 or 4 years that they had lost over $2 to $3 million. On the office that didn't bill any medication for 25 years, just do the math on that one. That one just, I was nauseous after that one. But there's little things like that, not billing for, if something is, when you're dealing with ultrasounds, if you're doing some extra services, if, there's just some extra things that some practices miss, or there's things where the doctors may think that, this is an easy patient for me to evaluate. So this is maybe a low level visit or a visit that's minimal level under the new guidelines. And I'm looking at it from a chronic condition standpoint. How many chronic conditions did they give, the status of those chronic conditions that they're addressing and they're following? And then were they clear that they're doing prescription drug management, or they're basically addressing those problems from a moderate level medical decision making? And when they were, even if I didn't have data points, that's a level 4 when I'm seeing a level 2 or 3. So there's things within an internal audit that if you can do it, I would try it first and then confirm or verify with an external auditor, and definitely email us, give us a call, see what you can do. Contact us. If you go to my website at terryfletcher.net, you'll see the contact us, and we'll get right back to you and write you up a proposal. At least you could bring it to your physician and say, you know what, we need to really look at this, because right now with lower reimbursements, you need to make sure that you're capturing all of your money. Otherwise, your doctor's not going to be in practice for very long. And so it's just really helpful to make sure that you're taking a look at all of that and everything. So I'm going to pivot a little bit for my coding question today, and I wanted to talk about something that comes up quite a bit when you're posting money. And for those of you that don't post from an explanation of benefits, if you're in the billing office, or if you are in the collection office, or if you're a payment poster, there's a denial code. And it's funny, I was watching or looking at something on the LinkedIn social media platform, and I was reading something, and I was like, and shout out to my good friend Christine Hall, who had liked something. I was like, oh, I just dealt with this, and it's denial code CO45. And what does that mean? So you get a denial from a payer, and it says charges exceed your contracted legislated fee arrangement. What the heck does that mean? So it means that you basically entered into a contract with a payer, and that contract was signed, and that you basically have agreed to adjust, not just they'll have obviously the PPO, EPO reductions, but you agreed to adjust your codes based on the initial evaluation codes and compensation. Well, I found that on several practices, this was a glitch in their system, that you didn't agree to anything, and they just put that out there, and they actually trend and track practices, and they know when they actually didn't do, when you're not following up on anything. And so they'll basically just start putting this out on different line items to see if you even follow up on it. And so you have to really watch this, because don't just write it off, okay? It comes typically with a paid claim. It means that the claim was processed and some amount was allowed, but due to contract with an insurance, maybe we're not supposed to bill the patient another than the allowed amount. And this is that CO 45. But if you didn't, enter into this fee arrangement, or you don't have any insight into that, you need to check, because I'm finding that it's more of a glitch in the system. Sometimes it'll also say CO 45 denial code with adjustment amount in excess of limiting charge. So they give you an allowable plus, so that's the difference between what you charged and what you billed. And then they pay you from that allowable or percentage. And then they're saying on top of that, you've got to write off even more money. So make sure that you have a copy of contracts if you're seeing a trend of that CO 45, because I'm noticing that that is a problem. So let's say that you had an insurance company that you billed $99213 and it was $100. In that insurance, they processed and paid that fee as, let's say, at $80. Okay. And let's say they said the $10 is going to a copay for the patient, but the other 10 is a CO 45. So it means you made a contractual adjustment or a contract with that insurance. Now, if that's the case, then that's fine. But make sure you know that you can't bill this to a patient. So you need to know what your contract state. I see this a lot of times on OB-GYN claims. I see it on a lot of procedural claims, gastro claims. And so it's really important to know some of these basics when it comes to those denials. Otherwise, that can really just run the gamut of all kinds of loss of revenue. So you should have a list of your denial codes, why they were denied, and actually define it further on what that means. So make sure that you're looking it up, you're figuring out what that means, and did you actually enter into these kinds of agreements where you're going to take that extra adjustment. Otherwise, you're just going to lose money, and we don't want you to do that. Okay, the Codecast podcast is also brought to you today by Gold Bond Ultimate Healing Lotion, skin therapy for nourished, healed, and healthy-looking skin. Gold Bond Ultimate. Okay, so my tidbit this week, my personal tidbit, is similar to what I was talking about last week, but I wanted to just kind of give you some 7 tips, let's say, into taking a break. I just thought this would be easy for you to understand. And just because I know you're just like, oh, Terry, I'd love to, but I just don't know if I can. Well, remember certain things. You're basically a houseplant with complicated emotions if you don't take that break. You want to drink water. Eat good and healthy food if you can. At least balance it with the bad stuff. Call a friend just to laugh on the phone. Take a walk in the sun if you can. A lot of people right now are vitamin D deficient, and that's contributing to longer COVID, long haul COVID, and even contracting COVID. Even though we're on the downslope, vitamin D has been tied to that kind of issue. So is zinc. Meditate, just sit there and enjoy the fresh air. And we just definitely have to learn to take care of ourselves consciously. So that includes blocking time in your calendar to do that. Just like you would schedule a work or client meeting, you need to schedule time for health. So we manifest what we focus on. And again, make sure, don't forget to water yourself. But, we just don't want to be, again, that house plant that doesn't get water or sun because you know what happens to that. So we definitely would end up with a fake plan, and that wouldn't be good for anybody. So just wanted to put that out there because I got a lot of positive feedback from last week, and they said, I don't know where to start. So start there. See if you can start there and let me know how you do. All right, that's it from me this week. Make it a great day. Make it a great rest of your week. And I'll talk to you next week on the Codecast podcast.
For more information on medical coding, billing, auditing, and compliance, including how to hire Terry, follow Terry on Twitter @TerryCoder1 or visit her website at www.terryfletcher.net. Podcast producer Joe Kuzma. Music producer Dassassin Music.